Hello, everyone. My name is Ritu Thamman, and I am a cardiologist and multimodality imager at the University of Pittsburgh. And today we will be talking about the next century of impact and advancing health through collaborative partnerships. And on stage here with me are four dynamic leaders, innovators, and parts of different business ventures that will advance our understanding, and I really look forward to hearing what they have to say. I just like to set the stage by saying one thing, which is, if you want to go fast, go alone. But if you want to go far, we have to go together. And so this is part of our mission here at the HA. We want to go far, so we have to go together. And we have all of these amazing company leaders to really help us expand our knowledge base to understand how we are going to do this, because this is they're big pieces of a puzzle. And that's why I had this image in mind that I put in this slide. So we'll start with the very first speaker. Why don't you come up?
Hi, I'm Evie Cunningham. I'm the Chief Medical Officer of Cadence. Cadence is a remote care delivery system that acts as an extension of the doctor's office. We do remote care, specifically remote patient monitoring is where our largest patient population is right now. We specifically focus on America's seniors. That's core to our mission, is helping America's seniors age friendly in their homes. The three use cases that we're currently deployed with for chronic conditions is congestive heart failure, diabetes, and hypertension. We're one of the largest remote care delivery systems in the country. We have over 70,000 patients that we're monitoring today, and we're expanding and growing quite rapidly. We're in about 36 states, and we have 22 health system partners. Some of the finest institutions in this country are partnered with us, and we continue to grow that portfolio. So specifically, I'm going to talk a little bit about the partnership that we have with the American Heart Association that we're super excited about. We know that heart failure is a really significant challenge for both our patients and for clinicians. Traditional care delivery is just not really set up well to get patients into good control, and we see this in our clinical outcomes and the readmission rates that we see, which is approximately 25% across all patients when they're discharged. 25% will readmit within 30 days, which is not only a huge burden for the patients and the clinicians, but also for the health systems because they experience financial penalties as a result of this. So this is a huge challenge for everyone. We know that the Cadence model works. So currently the way that our program is set up is that we enroll patients in the ambulatory care setting through their cardiologist or their primary care physician. And we know that, that we can make a significant impact in reducing admissions, in getting patients into guideline-directed care, and reducing total cost of care. And we've published in several peer-reviewed journals, and we've demonstrated those clinical outcomes and reproduced them. So we wanted to take this model and bring it upstream in a slightly different way. So we said, well, what if we could work together with the American Heart Association and with the core competencies that we have together, and in partnership deliver a connected care program in which we start to enroll these patients upstream at the time of discharge from the hospital. And that's what the American Heart Association Connected Care Program is. Now, one of the things that's unique about Cadence's platform and Cadence's capabilities is that we not only have technology, operations, and logistics, but we also have a multi-specialty, multidisciplinary medical group that extends care beyond the four walls of the hospital, and we do deep clinical integration and EMR integrations with the health systems we serve. And as you can see here, these are several of the certifications and the capabilities that American Heart Association provides. The two yellow circles are the areas where we're focusing together and in partnership and bringing much of the learnings and the content and the capabilities that AHA has to our program so that we can deliver this in partnership together. So how it works, we identify the patients while they're in the hospital. So we identify we have specific eligibility criteria for this program. Then we conduct a teleconsult in the hospital and we engage the patient. We consent the patient, we educate the patient about the program. And then by the time the patient gets home, those devices that they would be monitoring themselves with would be delivered to their home and available for them. These devices are all cellular enabled. They're configured to the identity of the patient, and they're super simple and straightforward for the patients to use, because the average age of the patients that we take care of today is 72. So from a TechWity perspective, we really like to meet patients where they are. And then we start the clinical delivery. And the clinical delivery model, as I explained before, in the AHA Connected Care program, we are the provider of record. We are providing the transitional care management to these patients. So that means that we titrate their medications, we order labs, we get them into guideline-directed care, and then we coordinate their care. So these patients are very sick. As you know, they're in the hospital, they're much more complex. So we have a high-touch clinical model where we're meeting with these patients almost weekly, and we're helping to address their social determinants of health and any barriers or other needs that they have to overcome to keep them out of the hospital. We currently are live in 4 hospitals. So we launched this program. We've been in the planning stage together over the last year, and then we launched the program this September. So it's been pretty recent. So it's been just a couple of months in these 4 hospitals. And it's been an incredible experience so far. There is no cost to the health system to launch this program. We can work with any electronic health record. So we actually have different EMRs in every health system that we're serving today. And we plan to expand this model of care across the country, because part of the reason that we came together is because the AHA was hearing very loud and clear as well from many of the health systems across the country that this was a huge pain point and something that needed to be addressed. You can see over here on the right some of the different components of the infrastructure that Cadence brings to the program, and obviously the amazing content and support that the AHA program brings in the partnership together. So that's it. So I guess we'll have Jeff come in next.
No, hang on a second.
Oh, okay.
It's a question.
I actually have a question. So in your care transition for the patients, how successful have you been? Because that's, of course, where we lose a lot of patients.
Yeah.
In that from the hospital getting home, and then by the time they come for their outpatient visit, they really don't know what meds they're on or
Right.
what happened. And how how successful has that program been for you?
For the AHA program specifically?
Yeah.
So we're still early stages. So we're with our first couple dozen patients. As you know, it's a slow growth process. I think we're learning a lot. So the one nice thing about being a tech-enabled services company is that we're small, we're nimble, and so we can iterate. So we're learning a lot about what's the right point to engage the patient during their hospital journey, right? Because if you engage them too early, it's so overwhelming, just the diagnosis of CHF or the readmission experience. So you want to make sure that you engage the patient when they're ready. Also engaging the caregivers and making sure that they have the right caregiver support or caregiver involvement, I think has been critical to the success. And then, as I had mentioned before, historically, we had enrolled patients in the ambulatory setting, so the patients are under better control. So this is a very different clinical model. It's much higher touch than what our remote care from the ambulatory setting model is. So we're much more frequently engaging with the patient and then there's a lot more med titrations. We are doing a lot of just education, reinforcing the medications that were prescribed. As you know, these patients, they come home, they're completely confused. They have their med reconciliation, discharge documents, and it's gobbledygook for a lot of them. So we're helping to translate that and coach the patient and educate the patient, doing a lot of reinforcement on med adherence and med compliance, and also connecting the patients back into the system. Sometimes these patients don't have a primary care physician, or they don't have a cardiologist, or they haven't seen the cardiologist in a long time. So really trying to help hold that patient's hand to get them back connected into the system in the ambulatory setting so that they don't end up in the hospital.
Fantastic work.
Thank
you so much. We'll have Jeff.
Good afternoon. No, that's not high enough. Can you hear me? Yeah. Good afternoon. I'm Jeff Bennett. I'm the Chief Strategy and Innovation Officer at Modivcare. Modivcare is an integrated provider of social services. We provide transportation to 30 million trips a year to people that need to get to dialysis or a hospital. Provide personal care services for 15,000 caregivers that go in the home and provide ADL services. And then we also have a monitoring division, which I also run. And the monitoring division monitors about 220,000 people at home. And then we also have a community-based program, which we're going to talk about today, around expanding access to care in the community. Okay. So first, I want to lay out the problem, which I think many of us know. Almost half of people that live in rural America have limited access to providers. 60 million people in urban, underserved locations also have limited access to providers. From a barrier perspective, individuals in rural locations go 10 to 30 miles to get to an appointment. For specialists, it can be 60 miles to get to a specialist. And the prevalence of chronic conditions, hypertension, diabetes, heart disease, 10, 20% higher for many of those conditions in rural America versus in urban locations where there's greater access. So that's the problem that we're looking to address. And a couple years ago, we actually partnered with the American Heart Association and CHTI, along with University of Rochester Medical Center, and we said, can we take the work that we're already doing at Higgy, which is a company that I used to run, in which we've provided individuals free blood pressures. 430 million blood pressure tests have been taken. And we've also had almost 10 million people create accounts to track their blood pressure longitudinally, which shows that there's good consumer interest in that. We've had 300,000 people join a heart health guide that the AHA and Higgy collaborated on, building lifestyle behavior change programs. So we said, okay, we know people are using this, but will they talk to a doctor at one of these stations? So we built a new form of the station. We partnered and collaborated with the University of Rochester Medical Center, and we launched this program. We learned from this program about what's the messaging you want to take to the consumer, to the person living in the community. And it wasn't about AI coming to your community. It wasn't about technology making it easier for you to talk and get ideas. It was actually, let's bring URMC to the community. They want the URMC doctors to be in their community. So we had to flip around some of the marketing, some of the engagement. And then as we ran through this program, we learned why people came to the station. So this was more of a, put it out there and see who came. Like if you build it, see who will come. It was kind of that first phase of building that. What we uncovered in this process is the predominant user was seniors, and 90% of the people said they'd come back for primary care visits, managing hypertension, urgent immediate care type of visits. So that's the first phase of this. Now we're moving into the second phase. So now we've built the My Life Check survey or program assessment onto the platform. So as a base feature, now we can use that to do risk surveys, to risk stratify, to drive education, personalized education to that individual after they do the assessment on the station, on mobile, on web, on text. It's omni-channel. You also can go to the stations to do self-monitoring and manage your blood pressure using the content and science of the American Heart Association programs that are deployed. And then there's 3 options of bringing care to the platform. One is we do have a 50-state clinical network. It's not designed to be primary care or cardiology, but it can do an annual wellness visit or something similar to a wellness visit where we could collect that information and share that into an exchange or something of that nature, so you can actually bring that access into the community and find out who needs to get to a primary care doctor, who needs to get to a specialist. So that's option 1. Options 2 is we can collaborate with health systems like we did with UMC. So we can bring their doctors, their nurses, their clinicians right on the station. And option 3 is we're collaborating with national providers that provide primary care, urgent care services. So if someone says, I don't have staffing to do this, we can bring that on. So those are the 3 options to bring access to care to the stations that we're testing out, piloting. And on top of that, with the Modivcare and partner resources, we can bring home monitoring for the people that need more extensive monitoring at home. So we do monitoring in the home. We can also bring transportation. It's a workforce and transportation opportunity, so we can train people in rural America to drive their neighbors to these locations or to hospitals. And on top of that, we can provide personal care services, doing ADLs in the home, in-home assessments. We have NPs that do in-home assessments through our partner company called Matrix Medical, so they could do that. And then finally, broadband access. We can bring broadband as well as this access into these community locations where we deploy these stations. So this is the playbook that we're working with and collaborating with the AHN. And we have 3 locations that we're in process right now. First is in urban underserved in Illinois. So we're partnering with a large MCO, actually Aetna, where we deployed this into community-based organizations where their members have limited access to pharmacy, to doctors, to food. So we're bringing it right where their CBOs are already engaged right now. And in the first 3 months, 390 screenings of their members, of people that they don't know, they haven't seen. So how do we bring that access into the community? 72% have a risk for hypertension. Again, they're not diagnosed yet because this was just the first phase of this, but next year we're bringing in the ability to provide telehealth on the station as well to bring that to the next level. In Nevada, we partnered with CareSource as part of their bid to bring rural access. So we're deploying this into very remote locations of Nevada. Again, same thing, community-based organizations. That is just going to get launched in January. And finally, with the collaboration of the American Heart Association last week, we deployed this into community locations here in New Orleans to do this with the American Heart Association. So those are the three pathways that we're testing out, and there's more coming down the pathway of what we're doing. From a takeaway, what are we doing? First of all, I think, Rita, you said this really well. This is not something you could do alone. You have to bring multi-stakeholders together. So, managed care organizations, health systems, CBOs are really important in this whole process, community leaders, and then the American Heart Association. So that's kind of our collaborators that we're bringing together in this. The right technology, and the technology isn't going to solve the problem, it just makes it more streamlined for the people that have the relationship and trust. That's really key. This is not a technology play, this is a relationship play, but this technology makes it easier for the people that have the relationships, that have the trust, to bring this into their communities. And then finally, getting the right data and the right actions, right, to connect you to the resources in the community. Again, this is not meant to be a siloed solution, this is navigating you to the resources that are already available to you. So this is what Modivcare and Higgy are doing in collaboration with the HA to bring access to care to rural and underserved communities.
Can you hear me? Yeah. Thank you so much. For folks out here, what is the thought about how do we pay for this? And perhaps we can get into the HEDIS measures and closing the HEDIS gaps, which is one potential way of paying for a service such as yours. Do you want to elaborate, or on that?
Absolutely. So when we walk through with the managed care organizations, our clinical network and our PC owner, our chief medical officer sitting right over there, a big part of this is how do we use that to the CBP measure, for example. But there's a bunch of other ambulatory access to care. There's a lot of quality measures that we can help our MCOs with closing, and so that's the key focus of this with CareSource and with Aetna, is really to deploy this and to identify how we can close their HEDIS and STAR measures in this whole process. That is the core value proposition that we're looking at in this process.
Just so the audience knows, how many of you all know what a HEDIS measure is and STARS, so everyone knows here? And obviously you know that hypertension is triple weighted, so that's a big one, and one that AHA is certainly very heavily focused on. So.
And member satisfaction, which is it's a survey, so it's a really hard one, but bringing this to the community so they don't have to drive 30 miles to access improves member satisfaction. That's quadruple rated. So blood pressure, member satisfaction, making it easy for these members are really critical things for these plans.
Do you plan to apply for the $50 billion rural health bill since we have lost our telehealth waivers? What do you think?
We are collaborating with a lot of different pathways to do this, because again, this isn't something you can do alone. We're just a piece of the puzzle. So whether it's with health systems or community organizations, with governors that we serve through our transportation network. And so in some states, we are the sole provider of transportation in the state. So how do we show them how we can bring transportation and access to care together?
Thank you so much, Jeff. It was
Thank you.
Excellent. James?
All right, thank you. So I have a few slides. I don't have anything on our products at all. If you do want to know about our products, like our tables over there, you can go and talk to Chelsea, and she can shepherd you through them. I mostly wanted to talk about the motivation of what we were trying to do and why we were trying to do it. Our company is a cloud-native, zero-footprint, end-to-end AI company that evaluates coronary CT angiograms in a cloud-based environment, and then delivers that information in the context of a comprehensive care management platform. The care management platform is like that we try to get every single actionable metric for coronary disease out there, including atherosclerosis, the stenosis that is sometimes caused by atherosclerosis, and then the ischemia that is sometimes caused by the stenosis. We wanted to deliver that to every stakeholder in the care pathway in a way that they could understand and act upon. And so it's sort of a closed loop comprehensive care pathway that aims to standardize and personalize evaluation of coronary disease. So that's our company. I myself am a cardiologist. I practiced for about 16 years at New York Presbyterian Hospital and Cornell Medical College, but I did my training at the University of Chicago, and there I met a former dean of the University of Chicago who said to me, like, if you're going to do something, solve a big patient problem, and you can always figure out a way to build a business around it. And so I never forgot those words. As we were going through this journey and developing our company, about 4 years into it, like, we met an innovative investor who just said, you know, I'm gonna ask you a question, I want you to answer me, I don't want you to think about it, just answer, whatever's top of mind. He's like, what's the biggest thing that you can do? And I said, screen the world for heart disease. He said, yeah, all right, I'll underwrite that. And so that is how somehow I ended up in this predicament that I'm in, trying to grow this company to try to bring new screening tools into everyday care. So here's sort of the problem statement, right? Do you ever wonder why we use imaging to prevent the most common cause of cancer, but not the most common cause of death, right? So when I was training as an internal medicine resident, we were recommending all those things on the left. And over the last 3 decades, they've been largely supplanted by all those things in the middle. What is the commonality between a mammogram, a colonoscopy, a lung CT, even a pap smear? Is that they all use some form of imaging to directly visualize disease at the personalized level at a time where things can be prevented, right? And then when I contrast that with the way that I was trained as a cardiology fellow, we're doing it the same way that I was taught, right? We look at indirect markers of disease, such as risk factors, cholesterol, blood pressure, diabetes, et cetera. It turns out those things don't work. They're not good diagnostic tools. They're good sort of therapeutic guidance tools, but they don't tell you who has disease and who doesn't. So what we've become is an extremely symptom-driven field, right? We wait for people to have chest pain, shortness of breath. Turns out that doesn't work in the majority of people, and then we put people on treadmills and take pictures of their heart, and that doesn't work either. So I think that it's time that we understood that the most successful care paradigms in medicine are not the way that cardiologists are doing it. We published a study a few months back in the European Heart Journal. We looked at about 5 million heart attacks across the country. And we said, look, if we do it the way that we're currently doing it today, are we going to solve the problem? And the answer is no. We asked some very simple questions. Of those 5 million heart attacks, it turns out the majority of those patients never had a symptom before their event. And when you look at those blue people, you can see about 30% of them don't have any risk factors. And about half of them don't see a doctor. And about 3/4 of them don't get treated with a single preventive medical therapy. Why should they? They don't have symptoms, they don't have risk factors, they don't have anything that's wrong with them, and yet they represent the majority of the people who will either suffer a heart attack or die from one. So we did about 20 years of large-scale outcomes research to try to understand what we were seeing on a coronary CT scan. We don't care about the CT scan. It's just a tool that we use to better understand coronary disease. And sort of 20 years of research is bubbled into here that when we started to focus on actual disease, like the atherosclerosis that builds up in the walls of the arteries, we realized that we could find the common link that linked every single important patient-centered outcome together. I mean, the first thing that we started was, does it predict future adverse events, right? Myocardial infarction, sudden coronary death, which it did. But people also come in with symptoms. So we said, well, does it predict ischemia? And it turns out plaque causes ischemia, so that if you don't understand that information, then you'll never be accurate in your ischemia determination. When you look at the bottom left, what we also realize is that you can see a certain plaque phenotype that would explain at a single point in time who's going to be a rapid progressor of disease versus who's going to be a slow progressor of disease, which I think has important clinical implications. And then the bottom right one is, I think, the most important one. When we treat people with PCSK9 inhibitor or statin, we see a 15 to 20% relative risk reduction. And then we pat ourselves on the back and say that was quite a positive trial. But what that ignores is the 80 to 85% of people who didn't respond. And yet you don't know who they are. Those are the people with residual risk. So if you could track plaque over time and figure out who's actually benefiting and who's not, we thought that that would be an important thing. And it turns out the atherosclerotic phenotypes that explain all 4 of those things are exactly the same. They shared over a Venn diagram that all converges on a high-risk plaque phenotype. So during this sort of time, we wanted to test out whether or not we could actually positively influence the natural history of people's outcomes by utilizing this information that we had determined through research. So we started a program about 13, 14 years ago at Cornell called Heart Health. And we didn't care if you had symptoms, which is about half the people, or no symptoms. Anybody walking through the door, we were going to do a CT angiogram on, and we were going to evaluate it comprehensively to get all of the actionable metrics for coronary disease. Then what we realized is that nobody understood the imaging language if you weren't an imager. And then the clinicians would remind me that we don't take care of pixels, we take care of patients. So you had to translate that information into something that was actionable. The third thing we did was we showed the patients their actual images. The number one thing that drives patient compliance is their perception that the condition that you're treating is actually serious. They don't think that cholesterol is serious. They see disease, they know that that's serious, and then that increases their adherence to 100%. Then we wanted to do was get past stratified group-based medicine and go into personalized medicine. So we would treat somebody with a treatment intensity that was commensurate with their disease burden. And then finally, we'd repeat the scan every few years because it got to be so safe so that we could understand whether or not we were actually getting rid of that high-risk plaque phenotype and then stabilizing their disease and reducing their risk of events. We went 7 years with 5 cardiologists without a single myocardial infarction in the practice. So we thought, hey, this is working, we just had no way to scale it, and that is why we started Cleerly, to automate that entire care management platform that you see there. What are we going to do with it? for the sake of time, I'm just going to jump to our North Star. We do address the symptomatic population. We've got 2 CPT codes that are reimbursable by both Medicare and commercial insurance so that you can get it for your patients. But our North Star is this trial right here, right? This whole big thing of what's the biggest thing that you could do, screen the world. Well, we decided that we were going to actually throw our hat in the ring and try to do it. So we will enroll 10,000 patients into a trial called Transform, a randomized control trial that has to date enrolled about 6,200 patients at 127 sites across the US. And what we wanted to do was truly make a screening trial. It is time. We understand the vascular biology. We've got extremely safe, non-invasive tools. Why are we using imaging to screen for the most common cause of cancer, but not the most common cause of death? And so this is the Transform trial. In the end, 7,500 patients will be randomized. We started with completely asymptomatic people, right? These are not patients. These are the people that you see on the weekend in the grocery stores or walking on the street, just regular old people. We chose men greater than 55, women greater than 65 with diabetes, pre-diabetes or metabolic syndrome without any symptoms. Turns out that's about half the people in that patient population or people population, and comprise about 105 million people in the US. And those people get randomized to one of 2 arms. The way we've done things on the left, which is checking your risk factors and blood pressure and cholesterol, versus looking at actual disease using imaging. And then because we have this residual risk problem, we repeat the scan every 2 years to make sure that the medicines are actually working and you can intensify medical therapy accordingly in response to the actual disease changes. Our primary endpoints are going to be a very hard endpoint of cardiovascular death, myocardial infarction, stroke, and so on. And what we wanted to do was make it literate, right? So if I tell you, hey, this person has a 1.3 remodeling index and they have a Hounsfield unit of 23 Hounsfield, nobody cares, right? So what we did was we created a staging system that received a breakthrough designation through FDA to make it very simple. It's simply 0, 1, 2, 3. Right? And Mike McConnell, who's sitting in the audience, he wrote a book called Fight Heart Disease Like Cancer. That's exactly what we're trying to do. Think about it. We didn't have a staging system for coronary disease. We have a staging system for every single disease: cancer, Alzheimer's, Parkinson's, asthma. This was the most common disease in the world, and we don't have a staging system for it. So what we did was we created a staging system that would correlate to prognosis. Once you get to stage 3, you have a 10-year, 50% risk of death and myocardial infarction. You are sick as a dog, whether you have symptoms or not, and then we're going to treat that accordingly. How are we going to treat it? We're going to treat it in a multi-parametric fashion where it's not just LDL lowering, but it's also triglycerides, metabolism, inflammation, thrombosis. And then what we've heard a lot, people said, well, I don't know if the positive predictive value is going to be high enough. Well, when you look at a screening test, not a diagnostic test of somebody with chest pain, but a screening test, if you look at mammograms, you'd need 570 women to undergo mammograms for 15 consecutive years in order to save 1 life. Colonoscopy, it's 1,250. You can see it's 323 to do 3 CT scans for lung cancer screening over 5 years. And if the hypothesis for Transform that seeing actual disease and acting upon that in a personalized fashion is better than population-based risk factors of disease to reduce major adverse events, the number needed to screen will be 30. So this will be a wildly cost-effective screening tool if the trial turns out that way. So that is our North Star at Cleerly, and I thank you for your time.
Thank you so much, Jim. Just a question for you. Obviously, there's some amount of radiation for each CAT scan. Is there a way, are you looking at if you follow someone with serial CTs, are you as a company also looking to see what the imaging markers are between, say, the first CT and the second CT and the third, to try to think down the road that maybe if we do a screening, we do it once, and then how often do we have to repeat it?
Yeah, it's a really good question. So, I mean, when we started this thing, the ACC had an Innovations in Prevention working group that had put out a paper that said 4-3-2-1, meaning if you don't have any disease, don't come back for at least 4 years. If you've got a ton of disease, come back in 1 year, because we want to match that to the disease burden. For the trial, we had to standardize it, so we went with every 2 years. Usually you don't see much in 12 months, and so it just wasn't worth doing. for the radiation issue, I think that's important. So, when I left my job at Cornell and New York Presbyterian at the end of 2019, our average radiation dose for a coronary CT angiogram was 1 millisievert of radiation. To put that into perspective, walking around New Orleans, you get about 3 millisieverts of radiation just from annual radon exposure. A calcium score was 3 millisieverts of radiation. It's literally 3 times the amount than a coronary CT angiogram if you do the CCTA correctly. And there's a ton of ways that you can reduce the radiation. So what we used to tell our referrers is stop ordering the calcium score, you're just quadrupling the radiation. We can get you such low radiation doses that are on par with a screening mammogram. We just don't want to do the calcium score because it ups the radiation.
Very good.
Okay.
Excellent. Thank you.
Thanks, everyone. My name's Jeff Wessler. I'm a virtual cardiologist, is what I've started calling myself. My kids call that a pretend Zoom doctor, and I'm hopefully going to tell you a little bit about the practice we've built, which is now a pretend Zoom practice. No, a real Zoom practice. So I'm going to take you back to about 10 years ago when I became relatively obsessed with this idea that our therapies and our interventions, diagnostics, and cardiology were advancing at unbelievable rates, and yet our outcomes were staying pretty stagnant. This is a trend that's now continued a decade later, and what I really have started to attribute this to is an access problem in cardiology. We have the therapies, we have the diagnostics, we know how to find patients, but we can't get them the care that they really need. And we see this again and again and again, that the real-world pragmatic application of this care falls so far behind what we've seen in clinical trial presentations and where the evidence should be. When you break this down, and I've put a couple of the stats up here which really drive this, we just see staggering amounts of cardiovascular disease getting worse and worse and worse, outcomes getting worse and worse and worse. And the map that you see in the background, to me, really illustrates why, or at least one of the reasons why. What you see is a county level map there in the back, and the orange counties are counties that don't have access to any cardiologists. So over half of the country that, at a county level has no physical cardiologist in place there. How can we expect these great cardiovascular therapies and interventions to get to the patients and people who need it most when we don't have the way to actually deliver that care and we have no infrastructure to get them the care they need? So Heartbeat came to market and said, we're really going to build a practice model to address this. And we're going to use all of these amazing interventions, these amazing diagnostics, and we're going to create a layer that can deliver them nationally at scale across the US. So we set about and built up a large national medical group. At this point, we have several hundred advanced cardiologists, general cardiologists, NPs, PAs, nurses, care coordinators, medical assistants, everything that a large clinical practice might have, with one major exception, which is all of the care we provide is done via telemedicine. Starting a telemedicine company pre-COVID was a little difficult, and we had a couple years to figure things out that didn't go so well. COVID really opened the door to say that telemedicine is a delivery model that can work, but we have to think of it as just that. It's a delivery model. It's a mode of delivering care, not necessarily a new intervention or a new process, a new therapy that we're bringing to market. So we had this major challenge, which was, okay, we now have this practice model that works, but we have to figure out the right way to get the right patients in market. And so about 4 or 5 years ago, we began to create these collaboration models with diagnostic and device companies, and it opened up the door for now how we think of wraparound care. And I'm going to illustrate this with a couple of different programs, starting with a heart failure program, which is one of our largest ones. When we think about heart failure very predictably moves from stage A, which is being at risk for having structural disease, stage B, which is having structural disease but no symptoms, stage C is symptomatic, and D is advanced disease. And yet we've really failed to identify patients early enough at a population level so that you can halt that disease progression. Still, the majority of heart failure patients are presenting at stage C or D, symptomatic in the hospital. And we want to be able to find those patients earlier. But what do you need to do so? Well, you need a diagnostic layer that can actually identify those with structural disease. So we came to market and said, well, we're going to take patients at risk for heart disease. These are stage A patients. Those who are eligible will get an echocardiogram. We'll use that echocardiogram to identify whether they have structural disease, and then use a televisit model to actually evaluate the patient, figure out whether and what medications to get them, and titrate those medications. And sure enough, when done so at scale, you can predictably prevent that progression to stage C in a relatively durable way over years and years and years. And we're now 8 years into our longest data set on that population, showing about a 20% reduction in progression of disease compared with standard care and the rest of the literature, where the literature stands. So that model was how we conceptualized this idea of diagnostic with wraparound care, bringing that at scale. This year alone, we'll do about 600,000 of these patients and bring them through this model. We've replicated this now in the arrhythmia space, where we take patients who are at risk for arrhythmias, get them a rhythm monitoring device, which is usually a patch. They'll wear the patch for a couple of weeks, send it back, and nowadays with these patches you can identify a whole host of things arrhythmia related and beyond that therefore can be managed, and it's really a barometer for often structural disease as well as the arrhythmias, which certainly deserve treatment. We do the same program across coronary disease in partnership with groups like Cleerly, and we're bringing the same to the market with vascular disease and now lipid management and ASCVD risk. So this model is one of take a disease state that is way undermanaged, provide a care model that lets you access more of the patients who need this, and then use the diagnostic to actually bring them in to the care model, because once you have that diagnostic, you can then create a model that actually manages them, and telehealth provides a great way to do so, easier access and lower costs. So I'll just show a few examples of what we've done to date. We've seen 1 million patients, over 1 million patients since we've started. Patient satisfaction with telehealth is really through the roof. Our NPS, which is a decent measure of that, shows people like to be able to access their care from home and only go in when needed. A telehealth model is exceptionally good at getting patients on medications, and so for disease states that are primarily medication managed, like early heart failure, chronic heart failure, arrhythmias, blood pressure, you can really manage those very well with telehealths and E&M visits. And what does this do for hard outcomes? We did our first randomized trial that finished earlier this year. We took patients who were leaving the hospital after a cardiac hospitalization, put half of them into standard cardiology care, half of them into heartbeat care, and then followed them for 90 days post-hospitalization. And the heartbeat care model was able to reduce hospitalizations, all cause about 45%, cardiac cause about 55%. So this care model works. The key is really getting it to the right patients at the right time who stand to benefit for it. And the main finding from this study, which we get asked all the time, what was it about the care model that really improved on standard of care? It was access. We are able to do in a 90-day period, we can do 10 televisits and another 10 check-ins with our care coordinators or medical assistant. It's almost impossible for a brick and mortar practice to facilitate that level of patient engagement and touch point, and keeping patients engaged on therapies that we know work and are evidence-based really does wonders to actually achieve the outcomes that you're hoping to. Thank you very much, and happy to take questions.
Thank you, Jeff. That was tremendous. Come a long way since 2020 when we were you're getting started. We were on your advisory, 4 of us, talking about how to get this off the ground. And really curious to see how you've engaged patients so well. Have you noticed that your patient adherence to medications is substantially higher? Like, for example, for CHF guideline-directed medical therapy, or just the fact that you're saying that you're getting 85% of your members to blood pressure target, that's incredible. That's way higher than what the national average is.
Yeah.
Is that
Yeah, so I mean, medication, we really like to think of ourselves as a medication practice, right? We are designed to do E&M visits, order and titrate medication. So adherence is the most important metric of that. So if you think about why are patients non-adherent, there are probably, if we asked everyone, there are probably 10 good reasons. Almost all of those non-adherence reasons can be addressed by spending time developing a clinical relationship with a patient, getting to what their issue is. Is it trouble with costs? Is it side effects? Is it their refill ran out and they couldn't contact the practice to get it? So these are all very addressable reasons. It's when they stack up on each other that you get the huge non-adherence problem we have. So to address that, you've got to figure out what that patient's key adherence or non-adherence risk is, and then address those head on.
It would be very interesting to see your data published on, what patient characteristics are those that lend themselves to more adherent behaviors versus not, because you can target them. Certainly at our institution, we've found that those patients that are not meeting blood pressure targets are the ones least likely to measure it at home or least likely to want to participate. So there's a real divide. It's like in those patients that we need to reach.
Yeah, 100%. We do have two reports coming out that we're working on publication. One in the heart failure population, and then one in hypertensives about adherence, and it does break down characteristics of that. And I think that is the key, is figuring out which are the drivers of non-adherence, and then directly addressing those in a short period of time.
Fantastic work. Thank you so much.
Thank you.
Thank you to all our excellent speakers, and look forward to all of your questions. Please join us at roundtables on either side. Come with your questions and join us in the conversation.